So I'm a gynecologist, of course, so I'm going to be talking about the female side of things. And where's my clicker here? And I think, as Tim mentioned, when we approach these patients, you have to remember that they are not coming into your office having had mind-blowing orgasms and a fabulous sex life before they had cancer, because you have to look at what is the rate of sexual dysfunction in the general population. And I think when people think in terms of sexual dysfunction, they think that's a very small group, because in the media, everyone's having great sex. And they think of it as something that's only in older men and women, and nothing could be further from the truth. Now, this is Jan Schifrin's data out of Harvard, looking at a very large cohort of women starting at age 18. And what we know is that 43% of the general population has some sort of sexual concern, whether it's libido, which is always number one in every population, the ability to become sexually aroused, problems with having painful sex, or problems with the orgasm. And then, of course, as someone hits that menopause age, the numbers go up, not just because of the menopause transition and the lack of estrogen, but because of comorbidities. So it's very important to keep in mind that long before your patient had a cancer diagnosis, there is a very, very reasonable chance that she was already having problems from the get-go. And people are always surprised at these numbers. They're like, really? How can that be? How can there be that many people with sexual dysfunction? Well, sexual response is complicated, and it takes every single organ system. And when I'm teaching medical students, I always say to them, I challenge you to name one medical condition that does not impact on sexual function, because you need an intact neurologic system, you need an intact vascular system, you need muscles, you need bones that function, you need a hormonal system that's intact. So it's really no surprise when you look at the number of conditions and treatments of conditions that impact on sexual function that we see so much difficulty. You also have to remember, biologically, we are put on earth to have sex for one reason and one reason only: to reproduce, right? Sick people aren't supposed to reproduce. Old people aren't supposed to reproduce. So it makes sense that there is not a normal sexual response from a biologic point of view. So this kind of all fits together when you look at the big picture. And then when you look at the cancer consequences, this group is all too aware of the different cancer consequences in terms of body image changes, weight gain, weight loss, scars, loss of hair. I once made the mistake of saying to someone, it's very trendy to have no pubic hair now. And she looked at me like, really? That's not what I'm thinking. I'm thinking that I don't feel like I'm a woman anymore. So we have to keep that in mind. Hormonal changes, which very often are transient, but in many cases are permanent, particularly if they're surgical. Not the cancer, but the treatment, whether it's radiation, whether chemotherapy, surgery, all have an impact on sexuality. A lot of people think it's all about the antidepressants. Yes, those are major culprits, but so is depression. Depression in and of itself is going to increase dramatically the rates of sexual problems. And then, of course, all the obvious things like the family issues, anxiety, and distress that go along with having cancer, in addition to the fact that just because you have cancer doesn't mean that you don't have other problems, which is why 90% of cancer patients experience side effects that are sexual. Does this mean they all care? No, of course not. It is appropriate when someone shows up to their doctor with a cancer diagnosis, what they care about is, are they going to live, not are they going to have an orgasm. But the point is that we know that these issues are there. And it is always striking to me that when a man is diagnosed with prostate cancer, and when he goes for that initial evaluation with his doctor, who talks about his options, whether it's radiation or surgery or whatever it is, and will say, and by the way, there may be sexual side effects. That's all I want anyone to do. Now, no one wants to talk about that initial visit, just to say this is a possibility. And if and when that is ever a concern for you, there is help. There are things that we can do to make that easier. So you just are acknowledging that this person is still a sexual human being, even though that is certainly not at the top of her concern when you are interacting with that patient. So I'd like to present a case. This is an actual case. This is Natalie. I saw her for the first time about a year ago in the Center for Sexual Medicine and Menopause at Northwestern. And she's 37 years old, known BRCA since her mid-20s, had completed her family, and decided to go ahead and have her prophylactic surgery, and went ahead with a laparoscopic total hysterectomy, bilateral salpingo-oophorectomy at the same time that she had her bilateral mastectomy. And completely unexpected at the time of surgery, she was found to have a stage 1 ovarian cancer, so she dodged that bullet because, of course, that was a cure because she was discovered so early. So she was, of course, very happy that they had discovered this cancer early on and went on her way until she presented to me a year later saying, I'm not able to have intercourse. Oh, and by the way, I don't really care, and I'm having all these urinary tract infections. So, basically her story was that she was told by her provider that she should use a silicone-based lubricant, and that worked in the beginning, and then over time, she started having more pain, more dryness, and then she even started to bleed after sex, and then she pretty much gave it up, and about 6 months prior to her presenting to me, she tried one last time, and, barriers to entry, there was no way, intercourse was impossible. And then she'd also was just miserable because it seemed like every time she turned around, she was running to the bathroom, and she'd had 4 urinary tract infections. And quite frankly, she said to me, I don't care, but my husband, our marriage is over, it's on the rocks, I don't know what to do, I have to do something to make this better. So after I spent a lot of time talking to her, I started with a physical exam. And I think, and I don't know how many gynecologists there are in the audience, but gynecologists are kind of too used to going for the gold, and they put the speculum in, with I had you at hello. And it's very important to take a very careful look at the external genitalia, because you're going to learn a lot just from looking. And one of the things that's always quite obvious, a very easy sign that people don't look for in addition to contraction of the introitus, is look at the urethra. It's just poking out there. The urethral funneling is pretty dramatic, and we see this when women have had long-term atrophic changes. And in fact, for anyone who ever still puts in Foley catheters, in the young woman, it's a little bit of a challenge because her urethra's kind of buried, and then as they get older, it's just sitting there, easy to spot. So you look at the urethra, we see that that there is a narrowing of the vagina. You can't tell so much from this picture, but the vaginal mucosal and the vestibule and the introitus is very, very pale. Prior to putting the speculum in, I do a vaginal pH, which is just putting some pH paper in the lateral wall of the vagina, because we know that in women that have vaginal atrophy, that the pH is well above the 4.5 that is normal in a young estrogenized woman. And then, of course, once you put the speculum in, it's very easy to see that there is complete loss of the nice folds, the rugae. There's no more glistening that you would normally see with lubrication. And in this woman's case, there was actual petechiae, which is why she was bleeding after intercourse. I also do a vaginal dilator assessment in which I take progressive dilators and gently put them into her vagina to see what she can accommodate. This particular case, she was able to get the 3rd dilator in, the orange dilator. I then always ask, what size is your husband? When the husband's in the room, they say blue. When the husband's not in the room, they say orange or purple, which is more typical. So I've learned to get rid of the husband when I ask. And Dr. Linda, who you will hear later, taught me the wonderful trick of keeping my dilators in a clear shoe bag so I can hold them up in the shoe bag and display them that way. I also do a very quick pelvic floor evaluation because we know that women who have long-term dyspareunia also have pelvic floor dysfunction from hypertonicity of the pelvic muscles. And even if you don't know the names of the muscles, if you do pelvic exams at all, you can put your finger in and press down on the floor of the vagina, and she will tell you if it hurts. So that was her exam, which was, of course, very, very dramatic. All of this is outlined in a paper which came out last year that Dr. Tesler was the lead author. I think I was the last author. Always good to be, I always tell my kids it's okay to be the last violin in the orchestra as long as you're in the orchestra. And I'm going to let Dr. Lindau tell you about that paper later, but this really goes through the details of the physical exam in the young woman or woman who with a cancer diagnosis. So basically her diagnosis was a severe genital urinary syndrome of menopause, secondary to surgical menopause. We no longer use the term vulvovaginal atrophy in this situation because it is really an acknowledgement that there are estrogen receptors not only in the vagina, the vulva, and the range of the genitals, but also in the bladder and the urethra, which is why she was having the urinary urgency and recurrent infections. And then, of course, she had this secondary high-tone pelvic floor dysfunction. So we talked about a lot of treatment options. And there are many of them out there, including the local vaginal estrogens. There's a ring, there's a tablet, there's cream. We now have vaginal dihydroepiandrosterone, prasterone, which is now FDA approved. We used to have to do it compounded, which is also a vaginal insert. Of course, we have the SERM, espemifene, which is an oral agonist, estrogen agonist, which works very nicely, and then presented carbon dioxide laser of the vulva and the vagina. And after discussing all of these options, of which they are all safe, they were all appropriate, and they all work well, she declined vaginal estrogen on the advice of her manicurist and felt very strongly about that. She really wanted to have some laser treatments, but it wasn't covered by insurance. So she opted to go with DHEA prasterone, which was one suppository nightly. I then also referred her for pelvic floor physical therapy. And then, as Tim said, it is extremely important to get a couples therapist involved, even if they think they don't need it, because believe me, this does have an impact even on the best of relationships. And I don't know if you're familiar with ASEC, but these are basically certified sex therapists who have a familiarity with all of these medical conditions as opposed to just a general talk therapist. So what happened with Natalie? Well, 6 months later, she was actually doing amazingly well. She was highly motivated. She was having pain-free intercourse. Her urinary symptoms had disappeared. She discontinued her pelvic floor physical therapy. And she and her husband were doing very well. They'd seen the therapist. But she decided that she kind of didn't like putting something in her vagina every night, and she switched to the estradiol vaginal ring. So I then saw her again just a short time ago. She had no sexual complaints, and she had switched to a new manicurist who is not quite so opinionated. And that is Natalie. And I just also want to mention that I do have brochures out front about the Northwestern Medicine Center for Sexual Medicine and Menopause. And after we finish the panel, I'm happy to talk to anyone on a one-on-one basis about what we're doing here, because it's kind of exciting. Thank you.
My disclaimer is that I am a pediatric urologist, so urology training with 2 additional years of fellowship training. But really, when I thought about this, I trained for 16 years and I've been practiced for 10 years, and this is something I feel very passionate about. And I have to say, when I started out, this was something I was very interested in, was sexual health and cancer survivors, and nobody really was thinking about it. But boy, have we had a culture change. And I think the fact that we're talking about it today is amazing. And I am open to your questions during the panel, and I can't bring this up enough, which is echoed here. It's let's talk about it. Bring it up. And I think you have to bring it up when you're seeing a 3-month-old who's going to undergo therapy for pelvic rhabdomyosarcoma, and the dad asks me, will my son be a man? You have to bring it up, when that little guy is going to undergo his orchiectomy for a tumor. You have to bring it up when you see that patient who had a retroperitoneal lymph node dissection as a 10-year-old and now is 17 and can't get it up. So you have to bring it up. And I think the comment about not wanting to bring it up because you don't have anything to offer is a really important myth to address, because I can see as a pediatric urologist or as a urologist, we have some urologists in the room who are reconstructive urologists or fertility specialists. I know Dr. Brannigan would offer that perspective of we can put a prosthesis in it, we can inject it, we can, there's so much we can do. And I think that's important to let families know. So no matter what the problem is, we can help make it better. But it really does start with talking about it. And I think the other piece is it doesn't have to come from me. The comment about the white man talking is sort of like, the woman talking to the boy, but to the family also. And I think we need to coach parents from the beginning that this is something to anticipate during development, so that it's brought up. And also that it's common among all boys and teens to have that feeling of inadequacy or discomfort. And sometimes the best thing I can do is put them in touch with another teen who's kind of faced that similar challenge, and then they can talk to each other. The other piece is something I learned from the adolescent medicine folks and the adolescent gyne. And as pediatric urologist, I'm a pediatric and adolescent and adult urologist, but sometimes you have to kick the parents out of the room. And you just have to talk one-on-one with that teen and say, gosh, is there something you want to bring up now that your folks are out of the room? And they'll say no. And then you have to push it a little bit. So let's talk about, are you having spontaneous erections in the morning? Do you know what that means? So I do think that piece about feeling comfortable with it comes with bringing it up a lot. And again, I've had a lot of experience talking about it, but if you at least bring it up before treatment, bring it up during treatment, bring it up after treatment, and have this on your radar beyond just the cure and the other toxicities, and knowing that if you have access to multidisciplinary resources, which I know sometimes is not that accessible, something can be done. And it also involves very similar, just a history and a physical. So this was a humbling experience when I was involved in this project, and Lillian is in the audience as the senior author, when we tried to come up with guidelines around sexual health. We looked at the data, and really it was limited and needed, and we had to extrapolate from a lot of the male adult data. And we came up with the thought, take a history and take a physical. Even if you were just to assess Tanner staging, that's the first step. For a lot of the physicians in the room, they're not even comfortable doing the GU exam. And it does involve doing the exam in a compassionate way, and getting that information, and then having the consultation available. So this was in 2012, and we've made some progress since then in terms of the data, but I really encourage all of you who are interested in this field, there's a lot that can be done and needs to be done in terms of additional information for patients and families. So this is a paper, you can look at some of the tables. And this was also looking at a childhood cancer survivor cohort, specifically and compared to their siblings, looking at the erectile function. And we have as urologists these nice questionnaires about incontinence and nice questionnaires about erectile function. And sometimes it's nice to just have that questionnaire and then go from there. And what this study demonstrated was, compared to siblings, cancer survivors were having less sex and they had more erectile function. And what we know in urology is there's a lot of options for treating it. And so just being aware that that is a risk and being aware that there's a lot that can be done. So on that note, I'm open to questions during the panel. I'm humbled to be on this panel, and I'm really thankful we're talking about it.
Hi, thank you very much. That was very, very interesting. So I have actually a list of 6 questions, but I won't ask them all now. I'll just start with one and then give other people a chance. But I'll ask 2 right now. So, for anybody to answer, and you might have differing opinions. The first is, how can practicing MDs get this training to learn how to address sexual functioning if they don't already have it? And then 2, how, if at all, is the conversation modified to discuss this when you're talking about pediatric and adolescent patients?
Well, I'll start with the training because most people are not trained in this, as you know. I give one lecture to the medical students, and as best as I know, that's pretty much the only lecture that they get. And I think from my point of view, I don't really expect everyone to be really trained in this. What I really want is for people to be aware and refer them to people who are trained in it. And I think that's really important to understand that we can't all be experts in something. And we're lucky in Chicago because we have a number of institutions, University of Chicago and Northwestern, where we do have specialists in this. But what I encourage every single specialist to do is to ask the question. And as has been stated a number of times, nobody wants to ask a question that they don't know the answer to. If someone says, I can't have an orgasm, and you have nothing to say, but I'm sorry, you're not going to ask that question. So that's not the question you should ask. The question that every practitioner should ask is, do you have any sexual concerns, such as, and you have to make a list because they don't know what you mean by sexual concerns, such as loss of libido, the inability to have an orgasm, or are you having painful sex that you would like to talk to an expert about? Just as you would for any other specialty. We all don't know everything, but you're saying, I will get you in the hands of someone. And I think that's what's really important, is to ask the question and then to be aware of who you can refer to. And the other thing I would just want to add is every study has shown that even if you look at the doctors that do ask questions, they only ask them to married heterosexual women. Every woman should be asked. If she doesn't have a partner, she may be self-sexual, she may have a same-sex partner. I always say, even if there's no partner in your life, there's always Bob. We all know who Bob is, right? Bob's your battery-operated boyfriend, and you bet he is charged up and at the ready in households across America. And if she can't use Bob, she's going to be upset. So you don't say to a woman, do you have a vibrator? You say to her, when you use your vibrator, are you having problems? It will open the floodgates up. So that's how you have the conversation.
To get your opinion on the role of using surveys. I know that there are some very good surveys for sexual dysfunction in men, but in women there seems to be kind of a paucity of information. So how can we implement that in our practice? So for the busy provider, or, because really we should be talking about this, as you said, at diagnosis, during treatment, at the end of treatment, and then serially. So what's an efficient way to use surveys or screening surveys?
Well, there are a number of validated surveys for, of course, research purposes, such as the FSFI, and there are some shorter surveys as well. I've made my own surveys, which are not validated. They're not for research purposes. It's just a good way to introduce the topic because, as you correctly stated, a lot of patients will be much more comfortable filling out a survey. I'm amazed, actually, what people will write on their surveys. And it is easier to do that than to perhaps start the conversation. And also, I also want to just talk about the role of the advanced practice nurse because especially in the oncology world and some of the other specialists, they're so focused, there's so little time that they don't have the time, and very often it is an advanced practice nurse that is absolutely gold in terms of starting the conversation and having the conversation. And we can't ignore the fact that while some of the best sexual medicine experts in the country are men, it doesn't stop the fact that women are not comfortable talking to them, but they will fill out a survey. And I'd be happy to share some surveys with you after, some links.
It is a question of access. And hearing you guys discuss this, it makes me think, what might care look like for a rural population or a rural patient, or patient living in a rural community, versus someone who lives in an urban area who might have a specialist who is a 15-minute drive. And I know some resources were mentioned, websites, but I'm curious for a pediatric patient or a patient who's older, what resources might a provider be able to hand to that patient to deal with that, in between actual clinical contact?
Well, I'm going to do the 10-second plug for my book, which you can get on Amazon Kindle for $1.99. We just brought down the price. It's Sex RX, Hormones, Health, and Your Best Sex Ever, and that's what my book is. It was intended for people who don't have access to a provider, and it essentially goes through in excruciating detail every single thing a woman needs to know in terms of the challenges that she might have, not just from cancer. I have a specific chapter on cancer, and I specifically talk about chemotherapy, radiation, but I really talk about every single medical condition because there isn't the resources out there.